Okay.
Oh, there we go. Molly's here to ask you hard questions.
Oh, Chelsea. I'm here to learn, Hanifi.
No.
I'm very happy that Hanifi chose a trial that didn't show a difference.
Yeah.
And that it's not on the PDA. For a while there, we had a moratorium on PDA papers. No one was allowed to present PDA papers because there were so many papers on PDAs that I couldn't have it anymore.
So, but everybody has this presentation, like the paper, right? Like they read, I guess.
Yeah.
I hope so.
Okay. I have 1 more minute, and then.
Yeah. It was a combo of like the template for critical appraisal and a little bit of my science-based medicine introduction, which you've probably seen a couple times. Small amount of Chelsea pontification about critical thinking.
Okay, should I start?
Yeah, you might as well, because you've got lots to talk about.
Okay, I cannot see how the people came back. Okay. Anyway, good afternoon. Today I will present you some topic like well known for most of the people, but still there is an ongoing debate about it is useful or not. This is the vitamin A. Just technically, I should say, like when I was a resident, there was studies, especially in the measles epidemics in the undeveloped countries, and then we were aware about that used the vitamin A in a high doses in that time, where like it was very effective based on the studies to decrease the mortality rate or something. I think everything came from that idea, and then went to the baby side. So this is a study was just published in April 2024. It is a 7 years old study, like a 7 years to finish this study. It was I think it's organized very well. It is a German, Austrian, together. They did this study, and it is the title is Early Postnatal High Dose Fat Soluble Enteral Vitamin A Supplementation for Moderate or Severe Bronchopulmonary Dysplasia or Death in Extremely Low Birth Infants. It is a no-white study, a multi-center, randomized, parallel group, double-blind, placebo-controlled, investigator-initiated phase 3 trial. Then I will mention what are the meaning of those. Okay. So, you know, the bronchopulmonary dysplasia or the chronic lung disease of newborn is very, like not very, but the common problem in the extremely low birth babies. And then there are many medications or the like some strategies to decrease or to prevent this, but so far there is nothing like a miracle for this kind of problem in NICU. So most of the people are using the postnatal steroids, and some of there was, I think now is not very popular, nitric oxide trials and similar like a preventive or the treatment strategies. Not all of them are except the steroids. So, and then we know the high dose vitamin A was used in some studies. The results are very different. Some results are like okay, but some other results were not. So in this intervention or the study, they tried to use the high dose fat soluble enteral vitamin A supplementation in the extreme premature babies, and then the purpose was to determine if the high-dose vitamin A supplementation reduced the rate of moderate or severe BPD or death compared to the placebo. Okay, and this is a multi-center study. 29 centers, 27 from Germany, and 2 centers from Austria. So I'm just summarizing what was the study. The participants are like at the end was 915 extremely low birth infants. The birth weight was 400 to 1000 grams, and the gestational age was less than 32 weeks, 32 or less. And then they randomized this group to 2 subgroups, and one is intervention group received 449 infants with the high dose of vitamin A supplementation. It is a 5,000 international unit per kilo per day. And the control group was 466 infants received placebo as a peanut oil. They continued to regular vitamin A supplementation like 1,000 unit for every day. Anyway, so they did this the treatment strategy for 28 days after the like within 72 hours. I think it was the criteria 2.5 ml per kilo per day. They start this vitamin A supplementation or the placebo. So like it was from 2015 to 2022, the 7 years this study like conducted, and then overall there was almost 3,000 infants screened for eligibility in that period. Most of them exclude because of the decline of the participation, or there was a COVID in that time actually. Staff shortage affect the study, and then some other babies included in the other studies they discarded, and language barrier and the infections like death or those kind of things. 915 infants remaining was assigned as a randomization. So they did 2 outcomes. Like the main outcome was the primary outcome was the moderate or severe BPD or death at 36 weeks post-menstrual age. As we know, the 36 weeks is important because of the for the BPD determination. Actually, in this age group is 28 days is the first step of the BPD, and then the 36 weeks is an area that you can classify as a mild, moderate, or the severe BPD. So, and then the secondary outcomes were many secondary outcomes, but mainly was the like a retinopathy, intraventricular hemorrhage, neck, and then some other secondary outcomes. And also they measured the serum retinol concentration as a effect of the vitamin A absorption or the body concentration, like a blood concentration. So what was the result? As a summary, no significant difference between the high dose vitamin A group versus control group. It is 38%. Like there was a death and the BPD in the same rate in both groups. The adverse events, like they did like a huge list for the adverse event, like sepsis and some other like blood pressure problems and those kind of things. If you consider like this one is a 1 column for each, there was no difference as well. The high dose got adverse event 57%, and the control group 60%. And it is very surprisingly, they couldn't find any like a high retinol levels it was similar in both groups. That we need to discuss about why. Anyway, at the baseline, when they start, they got these retinol levels from the cord blood. And then after, I think they got in 28 days and the 36 weeks. So then it was a filtered paper, like a kind of neonatal screening test. They got this one and then a couple of drops and they sent to the lab. So this is the like a results, like as a table. So you can see there is no any change. The odds ratio is almost very close to 1, and then there is no difference statistically for sure. And then the per protocol population is like some of them, because this is the intention to treat population, right? Some of them are lost during this intervention. And then this the per protocol population is the remaining people. In those people, like in both population, intention to treat population and the per protocol population, there was no difference. Like all the results were very similar, death or composite outcome. So this is like a duration of the ventilation. Okay, one of the criteria was those babies should get some of type of the ventilatory support, like as a criteria, as a criteria. So this is like either they should get intubation or mechanical ventilation or CPAP or oxygen. That was the one of the inclusion criteria. And then, like if you look at the days of the evolving bronchopulmonary dysplasia, everything is very similar to each other. And then retinopathy was also, so it was the other secondary outcome. Intraventricular hemorrhage, I'm just checking, they couldn't find anything. So like all the results are necrotizing enterocolitis, focal intestinal perforation. As I told you, they did many secondary outcome measurements. They couldn't find anything. In a conclusion, like they said, the high dose enterovitamin A supplementation is safe, but doesn't reduce the rate of moderate and the severe BPD or death in the extreme low birth weight infants. And then recommendation, the high dose vitamin A cannot be recommended for reducing BPD or death in the extremely low birth weight infants based on this trial. So I will go the critical appraisal, but so far, is there any question?
Good.
Now he's gonna go through the appraisal of the method.
Okay.
Yeah,
Okay.
yeah, it was a good overview of the results of the study in a decent amount of time.
Okay, so I'm going to the strengths of the limitation of the study. So the strengths of the study, the sample size was large. It was a multi-center, many like 29 center. It was double blind and the placebo controlled. The limitation was like the clinical practice. Still, you cannot exclude as a factor that affecting the baby's outcome. Then every center might be that they are universal, possibly they are following the universal guidelines, but like could be the practical why everybody could be different. Even like we are sometimes doing different in San Boniface and HSC. So the changing the definition, you know, the BPD definition was changed in I don't know which year, but they separated this one like a less than 32 weeker and more than like a and the older one like a kind of based on the age, like a 28 days versus 56 days and 28 versus like a 36 weeks. So the advance in the neonatal care can affect. Of course, the neonatology is changing every day. So, but like what are the clinical implications from this study? So they didn't change anything based on the things based on this trial, but they were thinking why the retinol levels didn't change, because they gave a decent dose of the vitamin A, and then the retinol levels didn't change in both groups. They were thinking this is because of the absorption problem. And then if this is absorption problem, what is the best way to give the vitamin A? Like inhalation, I am not very familiar with inhalation way, but we know the intramuscular injections are not great because of the pain problems in those population. So this is the future directions. Might be inhalation to me was very attractive, but anyway, might be in the future direction could be that those kind of research could be a possibility. Anyway, so let's come to the appraisal of this one. So I use the consort. The consort is the checklist for this kind of randomized controlled trial. And there are many things, is including the abstract, introduction, methods, and the results and discussion, those kind of things. I will come like very briefly. So the title. So the title is very important. If you look at the title of this article, it's a very comprehensive title, like is including everything basically. And then like if you go to the PICO, the population intervention, the comparison and outcome, it was like a briefly also is mentioning about this one, but the summary also is including everything. So that is good. The multi-center, it was told in this article is a multi-center study. So that is a good asset, increasing the quality of the article. That I will buy this one, because it can increase the diversity, and then the results could be healthier, possibly because it is more general, and then also reduce the impact of site-specific biases. And then randomized, it is very important because the randomized controlled trial that you cannot control the results. So it is a randomized controlled trial, treatment versus placebo, and it is a study give everybody the same chance and to assign in the group, and then this eliminate the selection bias and the balance, make a confounding variables, because the groups, when I look at the mother groups and the baby groups, this is one of the best studies so far I have seen. Like everybody's, the socioeconomic, everything is like totally equal to each other. So that was very perfect randomization in this article. And then is the randomized controlled trial. The other good thing, if you look at this pyramid, the randomized controlled trials is the top of before the evidence synthesis studies. If you look at the bottom side, there is an expert opinion I respect, but the randomized controlled trial in this area is the top. But we are not relying on only one randomized controlled trial, as Chelsea mentioned before. What was the parallel group? They said it's a parallel group. So they did everything simultaneously for each one. Like one study, like one arm didn't finish compared to the other arm, and they did a very good, reliable parallel approach to everyone. That is also a good thing for this study. Double blind is very important. We know the double blind is the participants and the researchers, they don't know which group they are going. And then it is very important because it prevents the bias. And then you cannot control the outcome if you blind. We know the double blind, there is a triple bias, the blind also. The triple blind is the statistician doesn't know what she or he is doing. And as the placebo controlled, I said is the vitamin A supplementation and the peanut oil, and the investigator initiated. So what is the mean? They said investigator initiated. So the study was designed, conducted, and managed by independent researchers and the clinicians. And this is not a kind of pharmaceutical company research. One of the problem nowadays, I did read this one like a couple of years ago, even in the big journals, like I think it was 40% of all studies were pharmaceutical support studies. So that is a kind of tricky, because I mean it can facilitate your research, but at the same time you can include some biases, then without intention or with intention, then the other people cannot recognize this one. So that's why this is the investigator-initiated study. It is important because they address important clinical questions without any commercial interest. And then they focus basically on the scientific and the clinical considerations, not the money considerations. And this is a phase 3 trial. We know the phase 1 trial, the initial safety trial, and then the preliminary efficacy trial are the phase 2 trials. And this is the phase 3 trials is more comprehensive, the evaluation, the effectiveness of and the safety, and that is the end of the phase 1, phase 2, and phase 3. The abstract, when you look at the abstract, it looks very comprehensive, and it includes everything from the background to the interpretation. So when we look at this one, the rationale was there, significance was there, and then the vitamin A importance was mentioned in the background. And the objective part, they did which kind of objectives they have, and then what is their like a goal, what they want to check. They mentioned all of them. The methods, they mentioned all the trial design, and then so double blind, the placebo controlled, all these kind of things, and inclusion and the exclusion criteria. Everything was mentioned in the methods and the abstract. The participants in this the article were mentioned very clearly. The birth weights, the gestational age, and the respiratory support, the exclusion criteria, everything were very, very clear. And then interventions also. So they did a dosage, how did they administer the vitamin A, the placebo, who prepared the placebo, how they delivered, everything was very clearly mentioned in this article, and I gave a check for this. And the outcomes, if you look at the outcomes in this article, they mentioned like a primary and the secondary outcomes very clearly. And then the primary outcome, as I said many times, it was the composite outcome of the moderate or severe BPD or death. The secondary outcomes I showed you, it was many neonatal morbidities, and they checked the retinal concentration as a secondary outcome. Any questions so far? Okay, I'm going. So the sample size. The sample size, how they calculate the sample size, they mentioned very clearly. And they did a power analysis. It is important for to avoid from the type 2 error because of the insufficient power problem. So they did, I think, very clearly in this one as well. So the methods, in the methods, they mentioned like how calculated the sample size. So it was 457 and the 457. The power was 80, that usually we use the 80% power. And then they used the odds ratio, and they mentioned all the tests and the significance. They used 0.05, that is very common. I mean, if you want more powerful, you can use 0.01, but you will get thousands of the babies for this. So, and then they mentioned also which kind of statistical way about the calculation. They use the randomization-wise the sequence generation method, like a block randomization 2 and 4. I think they did 2 consecutively, and then another 2 and 4, then the other group. But at the end, when I look at all the comparison tables, the gestational age, the maternal properties, the baby properties were very, very similar to each other. It was really good. And then the allocation concealment, the concealment mechanisms. So, like they concealed, like they hide everything from the like they didn't know who is getting which, because what they used as a placebo was an oil, and then that oil was also used for the medication, the vitamin A. So basically nobody understood which one is which. They concealed very, very nicely. It was labeled and it was sent, but the label was, nobody was aware about what is this. So that's really, really done very nicely. Okay, and the list, randomization list was done from one center and it was sent to everybody. And I'm just going. So nobody was aware about anything. They blinded. And the statistical method, when we come to the statistical method, to compare the groups for the primary and secondary outcomes, were very good. They used the logistic regression analysis. I will mention a little bit. So for the primary outcome analysis, as you know, they compared the BPD and the death at 36 weeks, and then they used the logistic regression. So that is the one of the like a common the statistical method to use, and then try to understand which factors are affecting the results. So they did this logistic regression test, and then they identified all the potential confounders, and then they did, I think they did like a nice comparison between the groups. The secondary outcome analysis, they used for the morbidities and the concentration wise, they used this secondary outcome analysis, and they used this Chi-square test. So you know this Chi-square test is a kind of table with like a 2x2 tables. So they use this one for the decomatous outcomes, yes or no. And they use the Wilcoxon-Mann-Whitney test for the numerical results, the duration of the positive pressure ventilation. And for the t-test, yeah, as you know, the Mann-Whitney is the non-standardized test, and the t-test or the standard population, and the other one is the non-standard population. So they used for this test for the numerical values. Looks good. And then intention to treat analysis they used because nobody finished the study. It was 400 something, and they finished with the 390. So, but the intention to treat analysis also can include all these the numbers as they finished the treatment, like the whole study. So adding this one increase the power of the study, and the bad thing might be, I don't know, it affects totally, but I don't think it affects the quality too much. But it is a very common very common method to in this kind of randomized controlled trial, because they lost many people during the 7 years. It's not like they used many babies during their death, and then they or they just for some reason they couldn't finish the study, but they included all this one when they allocate to 2 groups and start the study. And then I'm just checking the results, about their results. So everything was explained in the flow diagram. I showed some part of the flow diagram, and then the rest of the flow diagram. I didn't want to prolong this this lecture, but there was a very detailed flow diagram was showing which one lost, which one didn't include, all this kind of very clear. If you look at your article, if it is your hand, then you will see that one. And then the baseline data was shown in the table, and it was clearly there was no significant difference between the groups. That is good for the randomization, of course. And then the number of the participants, like each analysis, how many people included in that analysis specifically, all reported in the article. That was good. I'm sorry, I'm not showing on the article this one because I'm reading, but if you have an article, then you can see that. But if you have a question, please let me know. All the outcome and the estimations, like a confidence interval wise, everything done very properly in this the manuscript. And then at the end, as I said, there was no difference, significant difference between the high dose vitamin A and the control group. And like a subgroup analysis, also they did a subgroup analysis, like a including the like intention to treat versus remaining. They did a and then they also used the subgroup analysis in this one. Okay, adverse events and the serious adverse events all are reported in this article in the groups, and they mentioned about the limitations. One of the limitations, the COVID-19 pandemics, they mentioned very clearly about how this was affecting the study. Probably it was prolonged because of this COVID pandemics reason. And then they discussed the results with the evidence of the like previous evidence, the current evidence, in a nicely way, and then they clearly state the high dose vitamin A supplementation was not effective, and they mentioned about which alternative administration routes could be helpful for the future studies. And okay, so far what I mentioned, it is all internal validity. So the internal validity is the healthy of the study, like everything was done very properly. But there is also external validity that Chelsea mentioned in the previous lecture. Is this applicable to the other centers? That's the external validity. So can I use this research as like my guideline, or can I implement this one to do my practice? So that's the like kind of applicability or the external validity. I think the results were very neutralized, right? Because it was not claiming a big change or something. They did everything nicely, and then they couldn't find any difference. Remember, there are some biases in the article for the readers. One of the bias is an important bias. If the article shows a good difference or new change or something, that could be accepted nicely, then the other articles didn't show any difference. This is kind of, and then there are other biases, like we call the Babel Tower biases. If you published in this article in New England Journal of Medicine, everybody will accept this one as a perfect, and then they will buy it. If compared to the another low rate journals. So basically, so if I look at this one, looks like applicable in my clinical practice. And then because the studies included many different centers in Europe, like Austria and Germany, that is, I think that eliminate a little bit the site related biases also. And it is not one center, there's many centers. They are doing a little bit like different practices than each other. I think they increased the applicability of that. And they did register this one. It is also positive things as a trial registry. And then, so they did a full trial protocol included. And then also they did a very nice reference, at the end of this one, the study. And they showed which kind of the finding they did, the medication and the placebo were provided by Aristopharma, but they checked everything in their laboratory. And they also, good thing, I don't know what the number, I don't remember, but they did like a 90 visit or 900 visit or something. They went to the sites and checked how the everything is going, like they are doing appropriately or they are not doing appropriately. They checked all the data collection, analysis, everything, and they were very strict or very strict about this one. So like they didn't leave all the people by autonomously. They checked and they controlled everything based on the manuscript. Okay, the summary, the title and abstract looks like clear and informative. The identification of the trial was good. The trial of the registration number was also included. The introduction was good. Why they did this study, justification, and what was the research question and objectives, everything. The methods were also the participant criteria, interventions, the outcomes, the randomization, blinding, everything, and the replication and the validity assessment wise was done. You can do this study with this information by yourself. And the results looks like a transparent results. The recruitment, the baseline date, outcomes, everything. And this discussion, I didn't come to discussion too much, but they did a very decent discussion about why it was thought initially the vitamin A will make a difference in these babies. What was the initial study was showing these kind of good differences. Then after the other studies didn't show the same effect, and then they decided to understand clearly if it is harmful, helpful, or neutral. So they did this study because of this rationale. And then they did all the other relevant information, the funding sources and the protocol and the registration, everything, they disclose it. So I think that is my talk about this. That is my city, Konya, in Turkey. Okay, any question?
I mean, that was a great overview. And yeah, a good checklist. So the consort is that's one way to go through and evaluate an article. The consort checklist is meant specifically for checking how an article is written and how it's presented. So, but it's also a good way it is a way to structure your analysis and your appraisal of it. So if you're going to do it like Hanifi did, then you see, he kind of talked about whether it was presented, like, did they clearly define the type of trial? But then you have to evaluate, is that the appropriate type of trial, and talk about it. If you're gonna use the consort checklist, if you're gonna use the kind of checklists that are more dedicated for critical appraisal, then they work a little differently. But the consort checklist or the strobe checklist, depending on which kind of study it is, are very helpful for helping you go through and figure out whether things have been reported. Because sometimes when you're evaluating an article, the problem isn't that you don't actually know what they did, right? Because if you don't use a checklist to write an article, then sometimes they don't even put all this information in there.
Ganesh had
So-
a question.
Yeah, thanks for presenting that. That's very nicely presented. So again, with reiterating what Chelsea said, so there are simple checklists and complex checklists which are there, which you can analyze. So one of the basic checklists are the JAMA user guide. They have a checklist as well, depending on what kind of article that is. So it's well presented. So clearly, so a few points that you made, like just going through. Number one, like the reason the study was done, as all of us know,
Sorry, one
is
second,
because.
Ganesh. Hanifi, can you stop sharing your screen so that we can see everybody?
Oh, okay. So just let me see. Okay.
I tried to do it from my side, but it didn't let me.
Really? Okay. I'm just trying to do stop share is here. Okay.
There we go.
No, great. So sorry, I'm at home. So so essentially, when the whole idea about this came from the fact, like two major hypotheses, as you mentioned. One is the article by Jan Chennai out of Vanderbilt, which had shown originally that the IM intramuscular clearly shows a number needed to treat of 14 to make a difference. So that clearly makes a difference. But the babies have become smaller and smaller, and it's harder to give that injection, to them over a period of time. And therefore, alternatives have been thought of. That study also originally came about from the fact that the WHO had done work on respiratory diseases in the developing countries, and showed that supplementing vitamin A supplementation will decrease and help the lung functions as well. But so oral is a challenge. So a couple of issues, like one, this study was planned by a European clinical network. So it's a very well-established network, like a CIHR. It's a European type funding. So there's an investigative network which has done the study. So it's a very reliable study, as you correctly pointed out. Second, the funding for it was also from the European clinical networks data. So they follow similar to CIHR and NIH type protocol. So clearly you could see the quality of the study. It does cost a lot of money, but the money comes from the government in this case, or the network, as it is. So that does increase the validity. The medication, this particular specific type of medication, the vitamin A, was provided by one of the pharmaceutical companies, and they mentioned that in the article below. When you look at, so Arista, although they did not have any role in planning the study, but they were the supplier. They supplied both the carrier as well as the original. And the last, a few points that you mentioned about inhalation and others is that, so the challenge with vitamin A is it is a fat soluble vitamin. So whenever you're talking about fat and inhalation in the lungs, it becomes a problem. So think about vaping and tobacco. So there is some tobacco funds which have been used in the two articles in your article reference number 54 and 55. 54 and 55 in the references of this particular journal, they talk about the inhalation and they speculate about it in 2018 and 2020. And they are rat lung function studies. And the first one was intratracheal intubation. So you can't intubate 3 times. Like once you intubate and give it, the levels go up. That's what they demonstrated, and that's okay. That's a 2018. But the 2020 is intriguing because they did use a specific type of vitamin A, but what they did was something called plethysmography, whole body like inhalation. So Hanifi, you have done that. You remember that our old Bucksco apparatus, which had the plethysmography for mouse pulmonary function testing. So what they did is they put the mice for 3 days a week in a chamber and gave whole body, vitamin A. So they just put it into the chamber. That feasibility is a far distance away. So the challenges with vitamin A oral is it can get absorbed, but it gets pooped out because it's a fat soluble vitamin and it doesn't stay in the body long enough. Whereas retinoic acid, when it's given in the intramuscularly, it does stay and does help to protect against this. And the agents that have been used orally for carrying it and others are toxic almost. Like, so some of them have been castor oil based like substance versus this. So so the article itself clearly is one of those. I'm glad you reviewed it because it's an outstanding article about an old therapy which actually worked on evidence base, but we don't follow that evidence base because it works, but we don't follow it. So therefore, people have said that we try to find an alternative which will be suitable, and this alternative that you've tried to make it suitable has not yet worked. Like we have tried, like different people have done. So in a large scale, this was a nice large scale study which shows that vitamin A intramuscularly given 3 times a week at 5,000 IM has been shown to work, but orally has not yet been shown to work. So going to inhalation and others, that's a whole new like long journey. So so it is a long. The reason vitamin A, if it worked orally, is so inexpensive, so cheap that it's one of those generic, easily treatable conditions which will be cost effective, especially considering the NICU cost. But when you go through, as Chelsea said again, you can follow any trial. That it's worthwhile to look at the different checklists. There are simpler and some are complex. When you're analyzing it for a committee or you're trying to implement it from a quality improvement perspective, you may need more complex checklists such as consort. When you're studying it for a journal club, when you're presenting, so that because you can't even go through the points of the consort study in 1 hour, like here, because it takes time to sort of analyze and put that together. But I'm very happy that you actually reviewed the study, and so inhalation, if you want to do further research, Bucksco is still available. We can replicate that study in our lab and then go from there. I'm sorry to the fellows, like the equipment that he's talking about is a mouse pulmonary function type device where you can give ultrasonically, you can give nebulizations to the mice, or in this case rats, which can go into the lungs and help as well. Sorry for the long-winded talk.
One of my PhD research
topics.
Okay, any question or like a comment or contribution?
Brianna has a comment.
So that was like a fantastic overview. So thank you so much for doing that. I'll just introduce myself because I'm the odd one out here. My name is Brianna. I'm a fourth year student doing a visiting elective in the NICU. So going through the article, I think just from a methods perspective, there are a couple orange flags that I think are important for consideration and interpretation of the results. So the first is just a best practice point. So in the flow chart for participants, so there are 3,066 infants screened. That first exclusion criteria includes 174 infants for other reasons. They don't actually list the other reasons in any supplemental document. So there's no transparency as to how those infants or why those infants were excluded. So we know what the inclusion criteria are, but best practice is also to be very specific about the exclusion criteria. And we don't know what those are because they don't go into that. So like just a little bit of an orange flag. The second is just in terms of baseline characteristics and then whether or not data was appropriately analyzed. So although they present baseline characteristics in terms of raw numbers and then a percentage, there's actually no measure of comparability between the two groups, which is concerning. The two groups are of different size. And
Which one is different?
Table 1.
Yeah.
So the baseline characteristics, so the two groups are different sizes and there are some subjective measures included there, like AVGARs that may vary, like there are inter-user differences in terms of AVGARs, like we know that, and some other things. So there should actually be a measure of comparability between the two groups, like a standardized difference or something to tell us that those groups are similar, because they say they're similar, but just because the percentage looks like it's close doesn't mean it's actually close. And if they weren't, those would need to have been adjusted for in their analysis, but they don't do that. Nor do they say that they've done that and they're all actually statistically like comparable. So that's just a little bit of an orange flag for me because it tells me that they didn't do that extra step of making sure that their groups were actually comparable beyond a superficial, the percentages look close.
Okay, so yeah, I saw the table like a flow 1. So yeah, you are right. It's a 174. I need to check. Was there any explanation? Did you check if there is any explanation for that one?
Yeah, I opened the supplemental document and there's no like additional information as to what those reasons are. And so that's more of a best practice point. It doesn't really affect the rest of the results. It's more about like from a critical appraisal perspective, there's just some information missing. But I think what does affect interpretation of the result is the fact that they don't present any measure of comparability between their two groups. A percentage is not sufficient for that. A lot of journals are very, I think, lax on methodological rigor when it comes to these types of things. So it's not surprising to see, I think we see this in a lot of papers, but it's not best statistical practice. Like a percentage is not sufficient grounds for me to say that something is similar, especially when groups are different sizes, especially with subjective measures. And that's just, it leaves me with questions as to whether or not there are unadjusted elements of their analysis, because I don't have confidence about comparability of their two groups.
Yeah, okay.
Just one comment I'll have about that one is, if you look at the table 1, there are two, because of the extent of variability, the comparators that they've shown, there are 2 tables there. But whereas if you look at the table below, there they talk about the p-values and everything else in terms of differences. So sometimes space becomes an issue in publication. So this concern is easily addressed. If looking at the raw numbers, it is possible to potentially look at differences, which if they do agree or they do not exist. So that's not very difficult to do. And at this particular point, and the other option always is to write to the author to see are there any differences. So they've tried to categorize it as best as they can, and they've been transparent in that way. But if you look at the table and the way it is structured for me, and when you publish articles, when you're trying to save the space, what they have tried to do here is that they have put 2 parts of the table 1 and 2 on the side by side. Had they included 3 columns or 4 columns, then that wouldn't fit into it as it does in the page below. But having said that, you're right. These are things that should be looked at. I personally am not concerned in this particular article because there's the data to actually look at whether there are differences or not. But the criticism you mentioned that many articles don't do that is accurate.
Yeah,
Sorry, maybe I'm missing it. Where is the table that includes p-values for the baseline characteristics?
No, the p-values is not included. The reason it's not included, if you look at the table on the printout, you can see there are 2 tables put one side by side. The number of parameters are so much that it doesn't actually, if you were to make that into a 3-table chart, it becomes visually noisy, and some of the journal publishers do not want that information.
it is
It's a practical problem that it is very easy to calculate it from the numbers available. Had they hidden data and had not shown it and it just told me that they are the same, then that's different. Then that would be different. Yes, you look at it. If there is no data, then I look at it and then you say, is this true? Like, to what extent is that a concern? Is that a practical issue, or is it something that cannot be calculated if you were to do it yourself, or can you write to the author and clarify the same issue with them?
I can tell you one thing might be important. Like they did these flow that, and they before the randomization did happen, so they don't know like 174 will affect the results or not. If they lost something after the randomization, that's true. Like but before the randomization, if they fit the enough number for the study, and then it was like also they lost 907 because of the declining of the study participation. So like I think we should, like they documented 174 like wasn't included because of some other reason, but this all happened before the randomization. So I don't know like what is the point, but I will not concern about too much about that one. For somehow reason they couldn't include the babies, but that's all before the randomization. If something happened,
which is why I wasn't, like that was just that's a best practice critical appraisal point versus actually affecting the data. That 174.
I don't think it will affect because they have enough numbers. Yeah. And they lost many babies after the the intention to treat. They had still they had a good number to show that the results were very similar to each other, and then there is no I have no, because odds ratio is very close to the 1, like a 0.99, like what do you expect? It is a 0.98, then it will change? No, it will not change anything. So that's why I'm not very concerned about this, like a participation and everything.
Right. So I mean, so we're talking about 2 different things here. So we're talking about what should be presented, and that some finer details that for completeness should have been included, versus how the lack of that information affects your appraisal of how robust the data is. Because when we're appraising it, we need to be super picky. So if we're being super picky, there should be p-values in table 1 or some sort of comparison or standardized differences or something. And there should be, and you should have every reason for exclusion. Because it's possible, like if it's 174, yeah. Again, I'm not worried about it. The tables look very similar. So again, even if there were statistical tests, I have no reason to suspect that they would be that different. So those tiny caveats aside, those are not enough for me to distrust the results of the trial. So
Yeah.
like, but that's the point of critical appraisal, right?
No,
So
yes.
when you have a really good article that's very well written and a very well conducted study, the learning point is not, here's this really poor thing they did. The learning point is, here's the finicky things we should look for. For me, the kind of learning point from this article is, why was there no effect? So what was there no effect because there's no physiologic reason why vitamin A wouldn't work? No, because we have the IM trial, which showed a benefit. And I haven't read that trial in a while, but I understand that was a pretty robust trial. Like, we have reason to suspect that that trial is true, but yes, nobody wants to poke 500-gram babies 3 times a week, so nobody's doing it. So now we're searching for another way. So why didn't this trial show a difference? Did it not show a difference because the groups were unbalanced? We're pretty sure the groups were balanced. Did it not show a difference because it wasn't blinded well? No, we're pretty sure it's relatively blinded well. Did it not show it? So we're left with, did it not show a difference because it's a type 2 error? Did it not show a difference because our sample size wasn't big enough? Or did it not show a difference because it failed to achieve sufficient vitamin A levels to show a difference? And do we have any evidence from the trial that helps us sort those 2 differences out? Or can anyone think of any, right? So when you have a null effect, you have to think of reasons why we've had a null effect.
So I have got like comment
Yeah.
on this, like why serum retinol levels were both and like same in both the groups. Like, how is it given? Like, what's the method of administration? Was it given, like, was it mixed with a oil base, like a fat base, in that like neo-vita A? Is this like
It was mixed in their food.
Yeah.
It's
Or
in peanut oil.
like was it given? Yeah, like was it given separately or was it given with milk? Like as
First of all, like I think I have another explanation. 174 different reasons sometimes could be like a 10 some there is, and 15 another reason, then like 20 another reason. And then when you put all these kind of things in the flow sheet, it will make the flow sheet is very huge with unnecessary information. I think they avoid from that one, and they simplify. But the good thing, they mentioned every detail, like for after the randomization, if anybody lost the study, they mentioned even the one baby. It is, for example, there is one baby for the protocol deviation was gone. They mentioned about that after the randomization. That might be a reason for why they didn't mention separately for each reason. For your question, they did they already used the 1000 unit every day for the vitamin A. They gave this one additional, okay, and then the preparation was done from the one center for the each same amount, same color, everything was the same. Then they concealed what baby is getting exactly. Okay, so if it was the question of yours, then I don't know, my answer was okay for you.
Actually, my question was whether like this, I don't know whether it's a capsule, like vitamin A capsule, which you cut and give it like directly to the neonate.
No, it was a bottle. It says in the study.
Is a drop. It is a drop. They got as a drop, and then they gave one drop is, I think, is including 2000 unit. So basically, I don't know how they did count that one, but they gave as a drop to each baby. Okay.
And what was the solvent? Was it like peanut oil or like? Yeah.
It is what oil I mentioned.
Peanut oil, right?
Yeah. It was not castor oil for sure. It was, I think, one of the vegetable oils.
Because there are many other physiological changes that can be present in neonates, like how severe, like how sick was the neonate at that particular point of time, whether baby was having some gut issues like NEC or anything else, or like lot of factors can play in like oral absorption of a particular drug. So
Right, but do you have any reason to think that those would be different between the two groups? Because for that to account for a lack of difference, those distributions would have to be different between the two groups, and they're not.
yeah, so my next question is like, what were the confounders? Have they mentioned like specific confounders? Like, what would be like they did logistic regression analysis?
I can tell you the answer. So they used like there was a intention to treat analysis you saw, that was like a whole group, and anyone got some missing dose because of the NEC or something, if they fit less than 70% of the whole study medication, like they consider this was less than 70. If any baby got less than 70% of the required medication for the 28 days, they separated that one and they put to the intention to treat, and they analyzed the other group received full as a separate category, and they did analysis between those groups. Okay.
But in both the groups were like the disease or the problems
Yeah.
were similar.
Yeah.
Or,
They categorized that one as a non-compliance. Then they included in the intention to treat, but didn't include at the end of there was another group like a without any interruption, without anything. So they did those groups separately also. Okay.
so that will also depend on the mode of ventilation, like how much pressure were they giving to one particular group than the other group, and like what was the like intensive ventilation and the amount of ventilation that was being given, because that can also impact the lung itself and like the PD outcomes.
Yeah, but that was the within the secondary outcome. So they did compared to as a secondary outcome, they couldn't find any difference in those groups.
Well, the levels in the two groups were the same.
Yeah.
So that implies that the babies who got the vitamin A weren't absorbing it appropriately. So my question is, should they have done before, and maybe they did, or somebody did, before this study, taken some babies and given them escalating doses of vitamin A and looking at the level?
So I don't know this, but in the IM study, were the levels different between the two groups?
You know what, I can't remember.
Because if in the IM study, but okay, so here's my question. So this study didn't actually need to be done.
Yeah.
Like if in the IM study, the levels were different between the two groups.
Yes, they were different.
Correct.
Yeah, yes, they were different because, and the reason I can tell you that is I'm aging myself, but like I do, my research publication was published in the same journal, American Journal of Physiology in 2004. Actually, I did rat models of just saline, lipid, vitamin A, or retinoic acid, and I was looking at vitamin A. And Jan Chennai happens to be the same alumni as from the same alumni as Molly and myself. Like, so he had visited the alumni when I was a fellow in India. So this was very hot, before vitamin D became bigger. Like vitamin A was the main focus of a lot of the duration in time. The levels were different. The levels were different in that case. In Molly's question, you're right. Pharmacokinetic studies could have been done to see whether it actually works. But they went with biological plausibility rather than actually looking at the study, because there have been one or two much smaller studies out of India using castor oil related, oil related media, which showed that levels may increase. But you're absolutely right. Like before doing such a wonderful large study, which is very organized, expensive, very nicely conducted, a pharmacokinetic study of showing that. And this particular preparations matter. So this particular preparation is is made by one particular pharmaceutical company. So they could have at least in normal babies in a pilot program tested it out, or to see whether the absorption just changed the level. But that's a great point, Molly. Yeah.
Yeah,
Yeah, right?
you are
So we don't
talking
need,
about
so Ashish has raised some excellent points about why we might have failed to show a difference if our groups were not different enough, but I think we have a pretty clear explanation for why there was no difference. They didn't achieve any different levels. So right, so this, you're talking about toothberry science, right? Like, we didn't actually, there's no plausibility, if we can't actually change the vitamin, if in the IM study that this is based off of, the levels were different, which I'm assuming they are. Because it's even harder to say that that it had an effect without, like, if it had an effect without changing the levels, then it would be reasonable to do the study. But if we haven't even demonstrated that this type of supplementation changes your vitamin A levels, then how do we expect it to change your BPD?
That's the you're hitting the bullseye, because the studies that have been done currently in the inhalation and other techniques, in addition to looking at or have been measuring the levels and showing that when you give it intratracheally in mice models or rats, then the levels do increase. So without having documented if it doesn't increase, then then the question is, like, it's probably not been absorbed at all, or it's been flushed out. And it's a known problem with premature babies, like fat absorption is a known problem, and the higher dose doesn't necessarily get absorbed because the gastric emptying time and the intestinal transit time is relatively small, so that does impact. But you're right, like they should, on retrospect, they should have at least, and that is the reason why for 25 years nobody has tried the study. 30, because the minute IM works, the commonest person, the next idea is, oh, IM works, and vitamin A has worked in children for other conditions, so why not give that to this? The reason it didn't work was because the biological plausibility, it was not demonstrated. Right.
Yeah.
They could at least have done it in animals, because.
Yeah, so this is a waste of a beautiful study.
Yeah.
It's a waste of a beautiful study. I agree.
Yeah, but
It's a beautiful study and a beautiful write-up of the study.
they discussed during the discussion. I think if I am not wrong, you can check. There are some studies did the oral, and then they found difference in the retinol levels.
Yeah, I mentioned the castor oil related ones, like Ratnakar. They mentioned a couple in the discussion, but they are very small studies. You can't to conduct such a beautiful study without having that baseline established as a.
Yeah, I agree.
You could even stop it at 50 kids per group and seeing if your levels were different, right? Like, again, it's about responsible use of scarce resources, right? And how many kids, right? And you've enrolled kids in this trial, thus they're not enrolled in another trial. Because one of the exclusion criteria was enrolled in another trial.
Yeah. I interesting, they did do a midpoint analysis, right?
Right, but obviously they didn't.
That in their midpoint analysis, because they don't actually specify what was done in their midpoint analysis, just that they did one. But that's anyway.
Yeah, I think Molly, your point now.
Your point is right. Like,
yeah, when I'm thinking now, yeah, you are right. Like, it is a huge study.
Because so study-wise, that's why I was defending the study in the sense it's a beautiful study. Like, if I was looking at it from a construction perspective, it is almost as good, and some of those flaws, that orange flags that were pointed out, can be explained by paper, by our journal article not being fitting it in, or we can write to the author and clarify it. So the integrity of that is the conduction. They spent so much thought in that. I wish they had done a pharmacologic, kinetic study to show, yes, this particular preparation actually increases levels, like it would. And that's what the.
If they'd gone to 8,000, maybe they would have shown, like, maybe that would have been enough to have different levels, right? And then. Sorry, Molly.
Yeah, one other question I have is the study design. I mean, do you think and I know why they chose, or I think I know why they chose babies less than 32 weeks gestation, but is BPD a big issue?
They counted 1,000 grams
But
though.
the problem is, this study took them 7 years. If they used babies who were more immature, it would have taken them 12, 13, 14 weeks.
It might not have, because if you use immature babies, your baseline risk is higher, and so your number, your power analysis is a smaller number.
That's true.
Right?
That's true. Yeah.
It's easier to show a difference in the highest risk kids, so part of the problem sometimes is we actually run the cap too high, and so then we have to enroll a bajillion babies because our risk is so high, right? And so then another point about randomization is they're kind of lucky that this randomized so evenly, because sometimes when you have this wide of a spread, you have to do block randomization where you're.
Block randomization.
But they didn't do blocks by gestational age, I don't think.
It doesn't actually say how they did them.
I
Hey,
think, my interpretation, again, and this gets back to, there's some
Yeah.
room for improvement in the methods, is that it's block randomization by order of study entry. So like consecutive infants enrolled in the
Yeah,
study would be assigned either a 2, 3, or 4 block, and that block would get assigned either way. Is what's implied, it's not explicitly stated.
Yeah, like
Also,
they
did you notice they randomized twins separately, which is
Yeah,
always
I saw.
fascinating? I know, they randomized twins separately.
yeah.
And
Anyway, if I defend this study very seriously, I apologize. I know some of you expressed the concerns, and I defend it too seriously. No, I agree with you totally, and I respect what your concerns. This is not my study at the end.
No, Hanifi, the point is that part of critical appraisal is looking for any tiny issues,
Yeah.
but the important pieces, are they affecting your conclusions?
They paid great attention to the design of the study, to the writing up of the study, presentation of the data. But there was a fatal flaw.
But there was a fatal flaw. They skipped the biological plausibility setup steps, and that's an example of praying at the altar of the randomized controlled trial, my friends.
Okay, thank you so much for participating.
Thank you very much.
Yes, that was excellent, Hanifi.
Good
Okay.
afternoon.
You've opened up critical appraisal again.
Okay, thank you, thank you.
Yeah,
Okay, take care.
Okay,
okay, thank you very much.
thank you, Brianne.